we'd like to tell you today about a potential new source of adult social care data that NHS Digital and the Care Software Provider Association have been collaborating on. And listening to Claire's talk just now, I've realised that there is potentially some crossover with the Batchelor initiative as well. So that's very, very interesting to explore potentially. So this particular data set started out as a COVID-related data set, but could potentially have wider applications. But first, I'd like to briefly recap on the current landscape of official national data sets, for want of a better word, around adult social care in England. So currently, there are quite a few government agencies that collect and produce data around adult social care, and I think this mostly covers the sort of local authority view of social care in terms of what local authorities commission, and I think that's because this is the bit that the government has direct oversight of. Generally, I think it's fair to say it's collected only annually, I guess quarterly at best. It's usually at aggregate level per organisation that supplies the data, and it's generally collected in a very manual way, and available mainly through official or national statistics, which is my kind of day job in NHS Digital. But there are really serious limitations with this, as I'm sure people are aware. The main one, I guess, being the huge gap in the coverage of the full landscape of adult social care. Particularly, there's very little information on self-funders, on unpaid care, on care providers, care provider organisations, as we've heard, and the pathway between health and social care. And also, I think there's very little information about the outcomes for people in receipt of care coming from these data sets. And the COVID pandemic really quickly exposed all this, as we've already heard, and new data sources had to quickly be sourced and spun up to help manage and understand the situation. So specifically, I guess these are things like the capacity tracker, the domiciliary care survey, and the Vivaldi study. So that's a bit about the kind of background, but I'm now going to hand over to Robin Batchelor, who's the CEO of everyLIFE, one of the care management software providers, to tell the story of the development of our data set.
Thank you, Jane. The digital care management COVID data set is a data set that spans social care, adult social care, so both care homes and domiciliary. And it was started in July 15th after an initial pilot that we did in early March with NHS Digital. And the aim of it was to gather information to help care providers manage COVID-19 by understanding what was happening with those that were giving care, the caregivers, as well as those that were receiving care. So it started out March this year, and in its earliest state, it allowed care receivers to say whether or not they were suspected or confirmed of having COVID, and also to measure for care receivers, those they were looking after, whether or not they also were suspected or confirmed. That data set then grew to be a larger data set. And the key thing here is that the data is being captured by care workers that have already gone digital. So they've moved off of paper-based practices, and they're using digital apps to help deliver care at the point of care. And what this meant was that we were able to embed some processes that were voluntary, that assisted those care workers as they were going through their daily tasks, and allowed that information to be gathered and shared in real time with their supervisors to help provide better understanding of the challenges around C19 at the time. The data set focused, as I mentioned, on care receivers and caregivers. And it started out with what was the broad location and were you suspected or confirmed as your status. That then grew over time as we worked with NHS Digital to see what would be of more use, to add in an all clear status, whether you had recovered, whether you had gone to hospital, and in fact, unfortunately, whether or not the individual had died. And that data was being provided by over 30,000 caregivers and slightly more than 30,000 care receivers. So small in terms of the overall population of caregivers across the UK. It's just a few percent, but it is a large group, and it is across the UK, and it is quite a static, so therefore a useful data set that we can do trend analysis on. The daily process is that the data is being gathered as part of the workflow, and that is one of the key things. This is not about a supervisor having to gather data at the end of a week or asking care workers to call in or give specific data. It's being gathered as the care worker is delivering care in the way that they do with numerous other tasks. So it wasn't an additional burden. That data is then pooled if the care provider has opted in to share data with this program. That data is then pooled and provided to NHS Digital for further analysis only around COVID, and the program runs up into 2022. The perceived benefits is the reliability of data capture. It's happening every day. It's been going on since July the 15th. Because it's part of the process, it's easier to capture. And it covers both private and local authority, and it covers all different care settings. So it's comprehensive in its nature, and it's not requiring additional data recording. So it removes that burden. And that data is coming into the systems in real time. Which is then provided to NHS Digital as a daily upload. If I move on to the next slide and we talk about the dataset development and some of the challenges from a CASPA perspective, the Care Software Providers Association, the partners that that have the apps that are being used, there was an initial software development. So there was a sort of free of charge investment by all those that wanted to be involved, because under software as a service, you're always updating your systems to provide what your customers need. But it did require investment. Now, that investment was made. The systems were rolled out very quickly, the changes to the systems. And then there was some training required about customer workflow use. You've just introduced a new feature to the software. You've got to make sure customers understand what, why, and how to use it. There were further enhancements of that data set, and then we went into the consent process to share that data outside of the care provider to NHS Digital. And that was done on an opt-in basis in a very prescriptive fashion, which was not hugely... There was not a lot of take up for that. The opt-in did cause some problems in that a lot of providers said, we're busy, we don't know, we need to think about it, and then chose not to or did not actively opt in. So that reduced the overall data. The automation and daily collection is not a challenge, it just needed to be well managed. With the help of NHS Digital, that has been the case. So I'm going to hand over to Efrosini to talk about it from the NHS Digital side. Thank you.
Thank you, Robin. So can you hear me? Because I muted myself earlier. Oh, good. Okay, brilliant. So For us, this was a very exciting opportunity. We were able to sort of access data at the point of care and turn this into a data set. However, we weren't having direct influence in how the data is being collected. So we had to sit down as analysts and think about what did we need this data to tell us? What type of items did we need the software providers to be requesting from their care providers? So that was our first challenge, is without having direct access to the data collection point, how would we be developing this data set? The main issue we've had as NHS Digital actually was information governance. Even though this was an aggregated data set, we are governed by some very strict rules of how data can flow into our organization and how we could be looking after the data. So the opt-in in system was something that we actually asked for, and which, as Robin just described, caused some issues. Also, we had a lot of things to iron out, and we had to understand, because it was quite different to the other types of data sets that we are collecting as NHS Digital. As I said, we requested this opt-in consent, which impacted on the coverage. And this was something that we also had to understand. We needed to know how representative. It didn't matter that we were not getting 100% coverage of all the care providers, but we needed to know if it was a representative sample, and if not, would it be possible to weight this to make it, to be able to sort of project it into a representative sample. We also, having not got direct access to how the data are collected, we need to understand the data quality assurance. There were different software providers passing us the data. We need to be able to understand all the intricacies of the data before we are able to analyze it, but most importantly, before we are able to hand it over to other researchers, so that we can explain what could we expect. Are all the providers submitting data daily, for example? Are all the providers submitting data for everyone? These are things that we needed to be able to understand before we were able to make this resource available. And of course, because this is a COVID specific data set, the timescales are quite tight. If we are not to get it right at the right time, we're sort of missing the boat. So this was all happening at quite a tight time period. And also, we already were aware that we had sort of missed the first peak of COVID, and we were thinking about the second peak and how could this be tying in. If we can move on to the next slide, Jane. So yes, this was a great experience for us, and we learned a lot. We've got an amazing resource in our hands, but what we need to be thinking now at this point of time is, where are we going with this? So this COVID is sort of hopefully coming to, the crisis is sort of now coming to a conclusion. Is not quite, but you know what I mean. We've sort of we've got water in the stream, and we need to think, can this be extended? Can this be taken forward? At the moment, we have this amazing data flow that's been well established between industry and NHS Digital, but we need to be thinking, where are we going now? Should this be staying with NHS Digital, or actually what we would like to see is that this is made widely available in the research community under the right guidance? What we have learned, this has been a very a steep learning curve for us, because we've learned many things, one of which is, if there are multiple ways that people are collecting data, is there an incentive for people to provide us data? Should we, if we want 100% coverage from a data set, should we be thinking about mandating data provision? Also, if we are going down the opt-in consent route, actually, aggregated data might be a bit much. Maybe we should be thinking about record level data, because we're sort of shooting ourselves on the foot by reducing the data set. And if every provider needs to consent, then this is a good opportunity to be requesting pseudonymized, of course, but record level data. And also knowing what, how to be collecting the data, and the different data quality issues that are coming through, and how the data is being collected at point of care, which is quite different to other, healthcare providers. So where are we going with this? As I said, we've now have established this data flow. We are putting in place so that it's becoming, it's a system extract, and it's becoming more automated. Can we be continuing this? Can we generalize this outside COVID? However, we have to bear in mind that, NHSX is putting together their data strategy for social care, and this has to be around this new strategy as well. But we would like to hear from potential users of this resource and see if together we could think about how to build this data source going forward in time, and how you would think there could be use for this type of data going forward. So I think, this is where we're at the moment. And we would really welcome to hear feedback from researchers in the field. So thank you very much.